Thank you for joining us today for the National Hispanic Medical Association's PrEParados Empowering Voices for Black HIV Awareness webinar. I'm Dr. Oni Blackstock. I'm founder and executive director of Health Justice, and I will be your moderator today. The National Hispanic Medical Association is hosting this webinar in recognition of National Black HIV Awareness Day, which is held annually on February 7th, to bring awareness to key topics such as HIV care, prevention, stigma, and the lack of access to HIV resources within the Black community. Before we begin, a few quick housekeeping notes. All participant microphones are muted. We'll start with introductions and opening remarks, followed by speaker presentations. If you have questions, please submit them via the Q&A box for discussion. This webinar is being recorded, and all registrants will receive a link to the recording afterward. You can also find it at nhmamd.org or on our YouTube channel. With that, let's get started. Next slide. So a little bit about NHMA. The National Hispanic Medical Association, founded in 1994 in Washington, D.C., represents 50,000 licensed Hispanic physicians across the United States. As a national leader in improving Hispanic health, NHMA empowers physicians to address health disparities in collaboration with medical societies, students, and key partners. Through advocacy, education, and partnerships, NHMA works to create healthier communities for all. NHMA will share clinical tools and resources with you all at the end of this webinar. As mentioned, I'm Dr. Oni Blackstock, and I'm a primary care and HIV physician, and my career has really been dedicated to eliminating health inequities in HIV, and particularly those that impact the Black community. So I'm really thrilled to be here today with you. So today we are joined in a panel discussion with Dr. Anu Hazra, Associate Professor of Medicine at the University of Chicago. We also have Dr. Miranda Ward, Assistant Professor and Director of Equity at the George Washington School of Medicine and Health Sciences. Now, we'd like to move on to Dr. Hazra's presentation. He'll discuss more about his work and how it ties to the importance of Black HIV awareness. I'm going to give the floor to Dr. Hazra.
Thanks so much, Dr. Blackstock. I really appreciate the introduction, and I really appreciate the opportunity to speak with you all on this important webinar. Go to the next slide. So yeah, I think the next few slides we'll be talking about collective action and how to sustain and accelerate HIV progress, specifically in the Black and African American populations living here in the United States of America. I work predominantly in Chicago at the University of Chicago and at Howard Brown Health. We can talk a little bit about epidemiology and move forward in terms of forward next steps. The next slide. So, as we think about rates of new HIV infections in this country, while we had seen a downturn in new infections going into 2020, since the pandemic, we've been seeing actually small rises in new infections. And this may be due to post-pandemic effects in the U.S. public health system, but you really there's no other way to sort of work around it by understanding that there are actually increasing absolute numbers of new HIV diagnoses overall. And the overall goal of our ending HIV epidemic is to reduce the number of new HIV diagnoses to 9,500 by 2025 and 3,000 by 2030. We are already at 2025, and so you can see that we will not meet the goals outlined by the end of the HIV epidemic. So we need to be a lot more aggressive in how to reduce these new infections. And we can't talk about new infections without talking about disparities as they occur by race and ethnicity. Racial and ethnic disparities in HIV diagnosis do persist and have persisted since the onset of this pandemic. Racism, HIV stigma, discrimination, homophobia, and poverty and barriers to healthcare continue to drive these disparities, where we see that Black and African Americans account for nearly 2/5 of all new HIV diagnoses, and Latino, Latinx Americans account for about a third of all new diagnoses. There's also geographic disparities, as we see that over half of all new diagnoses in this country occur in the South or in the Southern region. And so again, this tells us, there are concentrated areas of new diagnoses that we should be focusing our efforts on, whether or not we are able to meet the HIV and the epidemic targets that we have outlined for ourselves. And when we think about HIV prevention, so we talk about pre-exposure prophylaxis, and Dr. Ward will talk a little bit more about her efforts in expanding uptake for PrEP as well. The CDC estimates that about 1.1 million Americans could benefit from pre-exposure prophylaxis. That includes all individuals in the country. And we see here in terms of our PrEP coverage by percent that between 2019 and 2022, we have seen rises in PrEP uptake. So more and more individuals in the United States are able to get prescribed PrEP and initiate PrEP. The next slide. However, the distribution of these prescriptions are unequal. And so we see here that as of 2022, 94% of white Americans who could benefit from PrEP are on PrEP, compared to only 24% of Hispanic, Latino, Latine Americans, and 13% of African Americans who could benefit from PrEP are on PrEP. This driving difference in a PrEP to need ratio, where PrEP is not getting to the people who need it the most, PrEP is not getting to the locations of the country that need it the most, continue to drive new infections. And the only way that we can alter the course that we're on is to, again, focus our efforts on populations that are most impacted by HIV, areas of the country that are most impacted by HIV, and making sure they have access to preventive mechanisms like PrEP in an effective manner. When we think about specifically PrEP uptake in Black populations, Black people represent the lowest percentage of PrEP users in 2023 at 14%. And Black people also have the lowest PrEP to need ratio, indicating the greatest unmet need for PrEP. And again, HIV prevention and treatment strategies focus on improving access to healthcare coverage and reducing health-related social and economic barriers for Black individuals may help alleviate and eliminate some of these inequities. And I think it's important to understand that as well. The next slide. And that really drives home when we think about social determinants of health. And I really have to lift a page from Dr. Blackstock's book of really thinking about this as more as structural determinants of health as well. That these are not just social determinants, but actual unique structures and economic systems that are responsible for most health inequities in this country. And it's our job as individuals who are at the forefront of thinking about the HIV epidemic, of how do we work around these structural determinants of health to best meet the unmet needs of our patient populations. And so here's a map of the priority states and counties in the United States that are part of the end of HIV epidemic. So these are by geography. Click the next button. And that's really based on where do we see new diagnoses in this country. And so our priorities, geographies for the end of the HIV epidemic is looking at states and counties that have the highest incidence of new HIV infections. And here we see states that have decided or not decided to expand Medicaid, at least as of 2019. There's a little bit more blue in this since then, but it's important to see the overlap. I mean, it's impossible not to appreciate the overlap of these two maps. Thanks, but because access to care is critical in ending the epidemic, and without expanding coverage to those who are uninsured or underinsured, how can we really move the needle in trying to reverse our course of the current HIV epidemic? And like we said, providing expanded access to healthcare coverage for all individuals is one of the greatest ways that we can actually improve PrEP coverage and reduce new HIV diagnoses, not among even just the Black population, but all people in the United States. And again, thinking about structural determinants of health, there are several structural level issues at play here. We know that United States is rife with residential segregation, where populations live in neighborhoods with higher HIV and STI prevalence and lower access to healthcare. We also know that housing equals healthcare. There was a study out of UCSF that showed that people who were homeless at HIV diagnosis had a 27-fold higher odds of death compared to those with housing. And we know the criminal justice system is disproportionately impacted by HIV. And we know certain populations in the United States, specifically African Americans, are disproportionately represented in this location. And then we have to think about medical mistrust or earned mistrust, resulting in centuries of historical trauma imparted onto populations here in the United States. And that also plays a major role in the reticence of certain populations of appreciating or taking up certain interventions that we are able to do in medical spaces. And really central to just the global AIDS challenge is stigma, and is as central as the disease itself. Although explicit biases against people living with HIV have decreased in recent years, subtle forms of implicit and unconscious bias persist. There have been efforts to normalize HIV to the same level as other chronic conditions like diabetes or heart disease, and this certainly does help reduce stigma. However, many lay people and even healthcare providers consider HIV as an exceptional disease and treat it as such, and this only increases stigma overall. And perceived stigma, specifically from prescribers, providers, physicians, is associated with a lower likelihood of accessing care, increased likelihood of missing doctor's appointments, and non-adherence to medication. People living with HIV may often engage in various behaviors to maintain secrecy, such as hiding their medications or using a less stigmatizing illness to explain their medication use. And the patterns of their healthcare utilization may change to avoid this type of stigma, such as using informal care without continuity or not disclosing their HIV status to certain healthcare providers. And our role in helping dismantle this stigma is really integral to help improve health access for individuals living with HIV. And some of my hot takes that I have to give in all my HIV talks. I think HIV is easier to treat than diabetes in 2025. I think HIV is easier to treat than hypertension in 2025. And I think HIV is easier to treat than coronary artery disease in 2025. And I think it's safer, and it is safer to have sex with someone living with HIV who is on treatment and undetectable than someone who is unaware of their status. I think these statements really should start to challenge our tenets and notions of what it means to be living with HIV in this day and age, and what options and the livelihood and perspective folks can have amongst the populations. Next slide. So again, our end the HIV epidemic is a huge step in utilizing well-known tools to eliminate HIV. However, the effects of U equals U or undetectable equals untransmittable and PrEP is limited by complex barriers at patient, provider, and system levels. Without addressing these obstacles, we will never be able to end this epidemic. And it's often difficult to assess certain state and local governments' commitment to ending the epidemic based on their policies regarding health access and human rights. We'd be remiss not to talk about what's going on a federal level as it pertains to HIV funding. And I implore all of you who are interested in advocacy to go to this website and think about how you can tell Congress to save HIV funding. And these funds promote not only access to care for people living with HIV, but access to preventable care to all individuals who are vulnerable to HIV in this country. These ongoing budget cuts will have major impacts on our ability to end the HIV epidemic in more ways than one. With that, I'd like to thank you all for your time, and I'm looking forward to a nice discussion at the end of this hour.
Thank you so much, Dr. Hazra, for sort of that really sort of in-depth coverage of the inequities that we see, the structural and social determinants of health that drive them, the role of stigma, as well as what we can do to help advocate for more funding and investment in ending the HIV epidemic. We will now hear from Dr. Ward, and Dr. Ward will be discussing the prevalence of PrEP uptake in Black women, and I'm going to pass the baton on to Dr. Ward.
Thank you so much, Dr. Thank you so much, first of all, to the National Hispanic Medical Association and Dr. Blackstock for moderating today's discussion. Dr. Hazrat, oh my God, let me tell you, those hot takes were the perfect way for us to jump into this discussion, right? So those of you logged in, hopefully you have some questions, some comments about those hot takes, especially as we go ahead and segue into, the role that stigma has in actually the uptake of PrEP amongst Black women. So I want to just first say that, happy Black History Month, everyone. Thanks so much for joining this timely discussion on HIV prevention in Black communities. My name is Dr. Miranda Ward, and I would describe myself as a social behavioral scientist whose research sits at the intersection of racism, identity, stigma, and health. And I engage in that work as an assistant professor in the Department of Clinical Research and Leadership, which is in the School of Medicine and Health Sciences at the George Washington University in our nation's capital. So if you go to the next slide, I did want to just share a couple of disclosures, because I'll say that as a cisgender Black woman, I am part of the US subpopulation with the fastest growing numbers of new HIV cases in this country. And so, these growing rates are actually preventable. So I do want to talk about the importance of PrEP, or pre-exposure prophylaxis, which is the only drug that people who don't have HIV can take to prevent themselves from getting HIV. I do plan to share some promising practices from a Gilead-funded project that I led as its PI, so that's one of the first disclosures, but I'm also a consultant for VIV's medical education curriculum. So if you go to the next slide, I just want to share, what can we expect from this, kind of 15-minute talk? Well, a couple of things. We definitely have to hone in specifically on the barriers, right? Ongoing, like we said earlier, structural and social barriers. And specifically, I want to hone in on some social, economic, and cultural barriers so that we can think about, well, what are some practical strategies that we can implement in our communities to really increase awareness, access, adherence to PrEP among Black women? And ultimately, what are some effective communication techniques for practitioners to actually enhance that engagement? So if you go to the next slide, I want us to actually, engage in a poll. But before the poll comes up, I just want to share that, I realize that we're, having a national discussion today, but the data that I'm actually going to present to frame this discussion is local to DC, which is where I live. And I think it's really important for us to kind of think about the district as the nation's capital and, just thinking about where we have been with the epidemic of HIV in DC and then where we are now. So that being said, by the year 2030, the district does aim to have 95% of the residents that are living with HIV on HIV treatment. So where do you think our most recent 2023 data shows that we are in achieving those aims? So the poll should come up and you'll see some options. Yes. Are we at 40%, 65%, 80%, or none of the above? All right, so cast the vote, lock in those responses, and hopefully we'll have a drum roll, please, so we can see our response. Is this response going to pop up, or should I just do the big reveal? Okay, so there it is. So actually, the majority of you say that we're at 40%, and quickly followed by many of you that said that we're at 65%, but actually, we're at 80%. Yes, we are at 80%. This is actually great news. And I'm glad that I actually did this poll so you can actually see that we literally, right here in the district, we actually have what it takes, right, to end the epidemic and serve as a model for how others can do the same in the country. And the reason why this is really important is because I've been living in DC for over 20 years. And I remember at the height of the HIV epidemic in the city, meaning literally 3% of the population had HIV. That basically rounds out to 1 in 20 adults, 1 in 100 youth, right? So we have definitely come a long way. And like I said, are a model city in many ways. So if you go to the next slide, I want to continue on with some more data from DC Health, because you'll see that over 11,000 people are living with HIV. And yes, this is an estimate, which means that there are very well even more people who do not yet know their status. But so far, this is the number that we do know. And when we stratify the data by race, we see that 70% of those with HIV are Black. And of the Black women with HIV, 7 in 10 are heterosexual. So yes, we do need targeted messaging for cis Black women on how to prevent HIV, whether that's preventing you initially from getting affected at all, or you have HIV, now we're going to try to prevent its spread. So for those of you familiar with DC, and I know that some of you are familiar with DC because I see some of my colleagues logged in and some of my undergraduate students. And so you'll know that DC is divided into 8 wards. And so what you can see in this heat map are cases of HIV are saturated in the same parts of the city where the majority of Black residents live. Okay. So that's, wards 5 through 8, but it's specifically the highest, again, for the heat map, the darkest red, right, are concentrated in ward 7 and 8, east of the Anacostia River. So it begs the question, is being Black a risk factor for HIV? After all, time and time again, we collect population health data by race, and we see higher numbers of Black identified people, right? So this is why I'm going to slow down, because I know I'm a fast talker, but I want to slow down and be very clear. Because if you don't remember anything from today's discussion, remember this: disparities are connected to racism, not race. So being Black is not the risk factor, even though, yes, we see the data that says, oh, look, all these Black people happen to live in this area and all this HIV happens to be in this area. It's absolutely not being Black, right? It is racism that most certainly is the risk factor. And, being Black is the prerequisite for discrimination, and therefore unfair housing, unfair policing, biased healthcare, among other structural determinants of health. So, at the crux of today's discussion is race, but we're also going to talk about gender, because ultimately we really want to explore what are some of the unique exposures to HIV that Black women have, in particular Black cis women, just given the data. So if you go to the next slide, we all know about intersectionality, right? None of us have just one identity. Instead we're really nestled, within the crosshairs of how all of our identities come together for a very specific social position. So although I'm going to tease out being a woman from being Black for the purposes of our discussion, we know it's not simplified in that way in how Black women live our lives, right? So first things first, sex, right, is one thing, and then gender is another. So if we start off looking at biological sex, we can hone in on female anatomy, right? And how the opening to the vagina does make it easier, anatomically, to get any sexually transmitted infection, including HIV. But that really only explains a very minute portion of what's really, exposing Black women to HIV. So the other factors are gender-based, like intimate partner violence. If a woman is in a relationship where there's a power imbalance and she feels unsafe, she, is exposed to violence, sexual assault, she doesn't have the ability to negotiate a condom or the decision to decide if and when they're going to, she's going to engage in sex, this definitely leads to the next factor around, not having consent. And socially, there's this idea that if you've ever had sex with someone, or you're in a relationship, or you're married, that consent is just automatic. Absolutely not, right? We all know better. Consent is required, right? Consent is specific, right? I'll do this, but I won't do that, right? So it's specific and it's ongoing, right? Regardless of your relationship status, regardless if I've ever had sex with you before, right? So you may ask, well, why would women, stay in a violent or unsafe relationship? For a variety of reasons, right? It can be around gender scripts, around this need to feel like you need to be in a relationship versus being single, right? That's gender norming, right? But also could be for security purposes, financially and otherwise. It can be for cultural reasons, such as, keeping the family intact. I mean, the list goes on and on and on. But what this does is it does create a codependence and therefore an unhealthy context for exposure to HIV, since your partner's sexual history and your partner's networks then becomes your, your sexual based exposure as a Black woman. And so, and then these are the things that we're talking about that we haven't even, honed in specifically to racism, right? No, I'm sorry, if you can go back to the slide, because I haven't even talked about race and racism yet. So it's actually very well documented how clinician bias affects healthcare. But let me add in, I actually conducted some interviews with, racial, ethnic, sexual, gender minoritized patients, but specifically when I was talking to Black patients, they were telling me how, they would actually feel offended if their clinician offered them an HIV test. You may be like, wait, what? Like, what? Offended? Why would they be offended? Well, just think about it. Are clinicians asking, every 70-year-old that, comes into the exam room? Are they asking that married woman, when they come into the exam room? So if we go back to intersectionality, there's like age, bias, there's marital status bias, and, couple that with racial bias, right? So racially minoritized patients tell me that they feel profiled if a clinician suggests that they get a test because they know everyone's not getting that recommendation. So that goes back to the stigma associated. Well, what are you trying to say? Why would you ask me to get the test, right? So and then of course, we have to talk about medical mistrust, right? Black women have the right to have concerns about research abuse, given how Black women's bodies have been exploited and experimented throughout history. But there's data that shows that sometimes clinicians assume that Black patients won't want to join clinical trials or learn of new pharmaceuticals because of medical mistrust. And that's not always the case. In fact, there actually are studies that show that Black patients noted that they would be inclined to join a study or research if the clinician they trusted, meaning they have rapport with them, invited them to do it, right? So I bring all this up because right now we don't have a safe or efficacious HIV vaccine. So PrEP is the next best thing. And it's just not widely used in the primary care setting or any setting, just like as the data Dr. Hosmer showed. And also it's not the case with Black women who actually are good candidates. So ultimately, this is due to one of the things we've been talking about, stigma, but also tropes and misconceptions and misinformation amongst all involved. So if you go to the next slide, I wanted to share that, the literature is actually very clear on why there may be low PrEP uptake. Some of it is related to, just not having awareness or knowledge about PrEP, right? Others, it's, related to trust or lack thereof. Basically, there's, low initiation or use or continuation. And there's, again, like I said, a lot of reasons for that. Of course, if you don't know what PrEP is, you're not going to take it. But even if you have heard of it, you may have some lingering questions, concerns over side effects or even your own candidacy for PrEP. But that's the thing, the relationship between Black women and their clinicians is so, so important. I can't just underscore that enough. Because if a Black woman suspects that their clinician is, being judgmental, they're going to be less likely to pose the questions that they have. So if you go to the next slide, this is why I designed a training to build the capacity of primary care clinicians to make HIV screening the standard of care. So just like when you go in and see a PCP and, no matter why you came in today, they're going to ask you a set of questions about depression, right? That removes the stigma. And so this is exactly what we need to do for sexual health, to make sexual health, right? It's really important that the messaging and training are led by Black women thought leaders. So this is exactly what I did with a 2-on-1 model, where I convened a racial scholar, the Nicole Hannah-Jones, also, was able to convene our very own Dr. Oni Blackstock as a physician and health equity scholar, the DC Health HIV/AIDS director, Clover Barnes, and then there's also a Black woman physician who focuses on mobile testing, community outreach, and just like the health of minoritized patients, Dr. Annette Gadabecchio. But ultimately, these are Black women thought leaders, and that's literally, this is a model. Like when we talk about, we want to engage, or reach out or, get the input or the feedback of, Black cis women on, okay, what are your, concerns about PrEP, or are you interested in PrEP? You should be talking to other Black cis women, right? So literally they become the experts that really can weigh in and convene these types of conversations. But not only did these experts lead a live online webinar, but they separately recorded content for our self-paced online course that clinicians could take for free CMEs. So, we had really great outcomes, as you can see here. And also shout out to Dr. Siobhan Onuma, who's actually on this call. She's an internist who actually did one of our clinician vignettes as well, another Black woman, thought leader. So if you go to the next slide, when thinking about HIV disparities, amongst communities of Black cis women, we really need to move away from only focusing on individual behavior and personal decisions, because disparities don't exist in individual people, right? I don't have a disparity. You can't have a disparity. Disparities are within and across entire population. So this really does call for structural level interventions and not patient level interventions. And that means that we also need to rely on culturally responsive communication that not only considers the role of culture among Black women, but also the culture of clinicians for how that shows up in that clinical encounter, the culture of medicine, you know, that maintains a power imbalance and a kind of paternalistic patient-practitioner relationship, and even, of course, the culture of racism affects it all. So I think that's just really important context at this, you know, for a much needed reframe for how we should approach PrEP uptake among Black cis women. So I'll end here on my final slide. So research shows that, you know, Black women don't respond favorably to risk-based language since they don't perceive themselves to be so-called at risk, right? So this really does call for targeted PrEP messaging to refrain from focusing on what Black, you know, women should stop doing. Instead, focus on why they should want to start or keep using PrEP. So I actually did a literature review and found that Black cisgender women respond positively to affirming messages about PrEP that really emphasizes their power, their control, their autonomy, their pleasure, right? And I'm also piloting a PrEP curriculum right now in DC for Black women using the trans theoretical model, which is basically like a decision-making model, like pre-contemplation, you know, kind of like before you think about it to thinking about it to actually doing it, like basically it's looking at the decision-making process. And I feel like as practitioners, there's a tendency, and, you know, when we are planning programs and we're saying if something's successful, it's like, okay, either the Black women are on PrEP or they're not. And that really flattens the complexity of like how people make decisions, actually. So what we really should be thinking about, you know, is really aligning our public health programs and our interventions and our evaluations to how decisions are made. So, you know what, it can go from, okay, we have some Black women who've never heard about PrEP, but now they do. That's a win, right? We have some Black women who are now considering it or they're thinking about it. They have questions about it. That's a win, right? We have some Black women who are now making moves to start it, right? They, you know, are now seeing a clinician regularly. They've established a medical home. Like, these are wins, right? Of course, then yes, they might, you know, initiate it, stay on it, and so forth. But in this way, I think public health practitioners really can measure these wins along the way and really make for a more concerted effort to exploring the impact that PrEP really has amongst communities. So I appreciate your time and attention, and I'm happy to answer any questions that you may have in the Q&A button. Thank you so much.
Thank you so much, Dr. Ward, for that very rich discussion around some of the barriers to PrEP uptake for Black women, the work that you did with the 2-in-1. Thank you so much for inviting me to be part of that very innovative curriculum. And then also just the importance of really tailoring messages to what would appeal to Black women. So now we're going to open up the floor for any questions. And I see Dr. Onuma has already put a question in the chat. And so I'll pose that to our panelists. And it's around Medicaid. So assuming there may be cuts to Medicaid and or more states that participate in expansion in the current climate, access issues will grow. What can we do to improve these gaps in the event that happens? So if there are cuts to Medicaid. So either one of you, and it's a big question, and one of you want to get started.
Yeah, I mean, I can start, and Dr. Ward, please feel free to jump in. I think there will be cuts to Medicaid. I don't think there's any way around that. I think given the current climate and given the current administration's sort of priorities, I think there will be significant cuts to Medicaids, and particularly states that have decided to expand Medicaid. How that trickles down to the patients that we see is going to be, I think, dependent on the state that you're in. There are certain states that will protect certain funding, at least within the states themselves, and not dependent on federal funds to continue care for folks that are uninsured or underinsured. But I think the states that are impacted by HIV the most are also governed by administrations that don't prioritize, you know, this type of healthcare. So I don't have like a rosy picture or a really happy ending in this. I think it'll be important for us to continue to advocate on behalf of our patients, and just how, you know, we were advocating before the ACA to make sure that our patients have access to healthcare, have access and understanding that healthcare is a human right and not a privilege. That continued advocacy is going to be critical in the coming years.
I couldn't agree more. And that's exactly why. So yes, it's definitely going to be, really different from state to state. And fortunately, like, living in DC, I know that we have kind of some of protections there. But I will say this is why, it was the work that I was doing was calling for routinized screening, right? Because when something's routine, it's kind of like, and again, when I say screening, it's not just the HIV serology test that it needs to be covered by insurance or, or public or private insurance, but actually the screening conversation, right? So routinizing and making that the standard of care, like, okay, these are the types of questions that we ask all of our patients. In times like this, when the administration changes, it doesn't matter because this is the way that you bring about care, right? These are the ways that you engage and interact with patients. And then that can be the conversation around, like, okay, well, depending on how they respond to this set of questions, will determine if they get the referral for, or basically get testing either at our site or referrals to another site. And again, I know that's funding specific, but I think that just thinking a little bit more differently about not just thinking about testing in a kind of diagnostic way, but thinking about screening and testing, so that when funding is threatened, those conversations and that kind of ethic of care remains. And then you just got to get creative on how to actually address the gap in the actual medical care.
And I will add, I think specifically as in regards to PrEP, we are in a different point in time in 2025 when it comes to PrEP medications with the creation of generic TDF-FTC for PrEP, which is indicated for anyone regardless of sexual transmission or transmission or injection drug use. The cost of generic TDF-FTC has come down to $15 a month and even lower. And so this is very different than the PrEP landscape that was existing back in 2012 when every bottle was about $2,000 a month, and even trying to cover the cost of just the medication was tremendous. So I think we are in a better spot potentially in the PrEP landscape specifically now to continue to have ongoing access. But to Dr. Ward's point, I think routinizing or making sure that we are able to create that the saying HIV and sexual health screening should be part of just routine care, so that is covered under sort of preventative care, et cetera, as much as we can, is going to be an important thing to do.
Yeah, thank you both. I'm wondering, maybe I'll go to Dr. Hazra. I know Dr. Ward spoke a bit about the DC context and what sort of the sort of patterns of HIV prevalence look like across the city. I'm wondering if you could just talk a little bit about what you're seeing in Chicago in terms of, again, communities that are affected, and specifically how your clinical organization works to address issues such as stigma.
Yeah, thank you so much, Dr. Lestock. So, I mean, I think, Chicago is the third largest city in the country, but I think it's a tale of two cities, right? We have very different cities depending on where you live and where you grew up and where you socialize and whatnot. So I practice predominantly in the south side of Chicago, which is historically a Black African American population of folks. Our life expectancy on the south side is 30 years difference from people on the north side, and these are all, again, direct products of structural determinants of health that impact people living on the south side of Chicago. It's not just health access, it's gun violence, it's these other sort of stressors that impact people living, working, breathing here on the south side of Chicago. And that goes directly into sort of HIV transmission and STI networks. We see higher, obviously, the number of new cases of HIV disproportionately impact zip codes on the south side of Chicago, and a lot of the work that we do at University of Chicago and my clinic at Howard Brown is, and I'm proud to say that my Howard Brown clinic in Hyde Park is the largest PrEP prescriber in the south side of Chicago, and really trying to make sure we're able to get PrEP specifically to Black population, specifically to Black women, and making them understand and feel empowered that this is a way that they can protect themselves regardless of what is going around them. But I think the story of Chicago is sort of replicated in many other parts of the country, where we see sort of Black populations disproportionately impacted by certain diseases and communicable illnesses that track along racial and socioeconomic fault lines.
Thank you so much.
Dr. Blackstock, if
yes.
I may, can I just add one more thing?
Yes, please.
Okay. So I know I was focusing specifically on Black cis women, but to bring in some of the outcomes related to Black MSM or Black men who have sex with men. I know in DC, one of the things that we have, been able to demonstrate, because we already knew this, but it's important to have data to demonstrate, is that housing is prevention, right? Housing is HIV prevention. And so, you know, really underscoring the importance of the social determinants and those structural determinants. So basically, there was a study that DC Health led, and they basically recruited you know, Black MSM to join this study. They were all candidates you know, for PrEP, but they were not on PrEP, and they decided to offer them you know, stable housing, some like workforce development. And they once all of those Black MSM were, you know, housed, and you know, they were employed, they noticed 100% uptake, you know, like initiation, let me say, to PrEP, and they stayed on PrEP. And so what this shows us, I mean, for obviously the public health practitioners already know this. They're like, oh, of course, that's not rocket science, but you know, sometimes you have to have those type of, you know, the data to like tell the narrative of, you know what, people are not going to prioritize a drug if they don't know where they're living tonight, right? Like, so your basic needs are not being met, then of course you're not thinking about PrEP, right? And if anything, sometimes you may even find yourself having more exposures to HIV because, you know, you're engaged in transactional sex, or because you don't have a place to stay. So it's like, oh, in exchange for letting me stay here, I don't have any money, but I can have sex with you, right? So then that's like increasing your exposure, right? So I think that that's just also really important, and I would love to see more studies like that, you know, in different kind of areas throughout the country to really, you know, demonstrate the importance of those social determinants.
Yes, definitely. I always say like housing is PrEP, access to, you know, employment is PrEP, like all of these things can
Exactly.
prevent people from getting HIV. And like we know it works, so let's just, you know, do it, have the political will to do it. Sorry, I have a puppy in the background. I hope people can't hear it screaming. Gosh. Okay, another question is, you know, for folks in the audience who may be watching, who may be community members, advocates, allies, what, you know, suggestions that you have for them. You know, this is such a like challenging time right now to also to feel hopeful of anything, but sometimes we're able to take like, you know, an action or do something that's sort of within the sphere of our influence, that can sort of empower us to continue to move forward and work to advance change. So just wondering, maybe I'll start with Dr. Ward. Is there any sort of advice you have for advocates or allies who want to play a role in working to end the epidemic, especially given sort of the current climate?
Such a big question, let me tell you, because each and day, this is something I always tell people, I always tell my students, like when people ask me like, so how are you? I'm like, do you really want to know how I'm doing? Like, given the state of the world, it's a very loaded question these days, right? But you know, like I say, when talking with my students, you know, these are students who are, you know, really kind of thinking about their values, you know, their civic and social identities in relation to like the world around them, and, you know, deciding on a career, right? So, you know, like, oh, well, do I want to, you know, be a public health practitioner? Do I want to be, you know, a clinician? Do I want to do both, right? So, you know, I will say, even though, yes, these are really hard, trying times, um, I found that when you are driven by, you know, purpose and mission and values, even though it feels daunting, it feels, you know, it can feel like it feels disempowering sometimes, um, holding steady, you know, steadfast to those values really, like you don't necessarily feel deterred. You feel like, okay, actually this is why I'm choosing this career. Like it's legislation like this, or it's, you know, administrators like that, or it's, you know, social attitudes like this, or geopolitical moments like that, that really you know, motivate and activate me and my values to want to do this. And I feel like, you know, it almost feels like counterintuitive. Like you would feel like you would actually have the opposite effect, but sometimes it also propels you to like, this is why I'm so needed, right? This is why I actually want to apply to this public health program and graduate public health school, or go to med school, or be a nurse, or whatever health profession, right? Because you realize that, you know what, the only way we're ever going to achieve health equity is to have racial equity. And so, you know, these are just some of the commitments that, you know, students and a range of learners have had. And I love to see that and inspire and help to mentor and cultivate that. Recognizing that in the meantime, we also can do tangible things like call our representatives. right? So like, it's kind of like one thing to say, oh, this is what I'll do later on in 3 or 4 years, right? I'll graduate and join the workforce. But today I actually can do something tangible, like Dr. Hasrub, shared with, calling our elected officials.
Yeah, no, totally ditto. And thank you, Dr. Hauser, for giving us something like really concrete and tangible to be able to do. And yes, and so also welcome your response as well.
No, I mean, I love Dr. Ward's perspective. And I think the other thing to think about is like, while it feels like the world is closing in around us, I mean, this realm of HIV has a storied history of activism and trying to fight for its own space in the healthcare setting, in research and whatnot. And so I think, while the last few years have been great in terms of us, getting good amount of funding, getting, visibility and trying to improve outcomes, that wasn't always the case. And I think, relying on where we were, 40 years ago and recognizing that yeah, people had to fight for the NIH to even fund studies for people living with HIV, but we had to really fight to even get drugs to market. While things seem really grim now, people were dying in scores. Young people were dying in scores, 40 years ago. So I think putting things in perspective, I think we've been there. I think as minoritized individuals, we also have this aspect of resilience that we're able to sort of rely on our sort of chosen selected families that give us some protective factors and in times like this. And I think, just kudos to what Dr. Ward was saying. It's like, this is how, there are tangible ways that we can make differences, and then also internal ways that we feel fulfilled by the work that we do. That, HIV doesn't care who's the president right now, that we are going to see HIV transmissions occur. And my role is to see how I can protect people from, keep people healthy who are living with HIV, and then offer, prevention for folks who are vulnerable to it.
Thank you so much. Both of those are just excellent responses. And it made me think about, Dr. Hodger, when you were talking, I think it was Dan Savage, someone who sort of lived through the early HIV/AIDS epidemic, said, we took care of our loved ones who were dying with HIV in the morning, in the afternoon, like we were protested, and at night we danced. And it was it was sort of the dancing and the fun and the joy of that really pushed folks sort of through the day. So yes, I think there's a lot of hope, and I appreciate what you both shared. There is a question, and I'll ask maybe Dr. Ward and then Dr. Hazard could follow up. We have a question. Okay, someone works. Okay, Arlen Funes works for Community Crisis Services in Maryland. How can I talk to women of color about HIV, that it's not the end of their lives, and how can I help them talk through their options where they feel like their life isn't over?
Thank you so much for this question. Yes. So I will say that we just have briefly talked about how there's been so many biomedical advancements in HIV, right? Like, going from didn't know anything about it. Used to, like, the first case in 1981, it's like called, gay-related immune deficiency GRID, right? And then now we know better, right? It's like, oh no, actually it's called HIV virus. And this is the virus that can lead to end-stage HIV disease. Which is the new way we talk about AIDS. But even with, okay, you no longer have to take 24 pills, you can take one, and now we have PrEP, and PrEP used to be a pill. I mean, it's still a pill, but you also can do the injection. Like, I'm bringing all this up to say that we've had all of these biomedical advancements, and socially, have we advanced in as much as we have, biomedically? And we know we have not, right? We know that even though we've come such a long way to the point where you can have HIV, and like Dr. Hazra said in his hot takes, you actually die from cancer, not HIV, or complications from HIV, right? So even though we know all of that biologically, socially, the stigma is there. Socially, the feeling alienated, ostracized, and the why me kind of gets there. And I realize that's so difficult. And so what I want to do is, do you mind, Dr. Hauser, if I like throw it to you to kind of talk about some of those hot takes? Because
Yeah,
I think that
sure.
was so important to help frame why someone shouldn't think of it as the death sentence that it used to be back in the 80s.
Yeah. I think, whenever we talk about HIV in my clinic, I don't try to minimize it. It's still it's a chronic condition someone's being diagnosed with. I don't want to minimize it and write it off like, oh, don't worry about it. Like, if I diagnose someone with diabetes, that's a big deal. Like, they have to now think about what they eat. They have to think about their medications. They have to adjust their lives around it. So It's not minimizing it, but recognizing it doesn't define who they are by any means. And so I always tell folks, I ask folks, like, do you know anyone living with diabetes in your family? And most more often you do know someone living with diabetes. And you think about, hey, that family member or someone close to you living with diabetes, do you see them, checking their blood sugars 4 times a day, that they're pricking themselves, or thinking about how many carbohydrates they're consuming, doing that math in their head, how it impacts, every part of their day that they're living through. And then think about HIV, and I'm literally giving you one tablet that you're taking daily, and that's it. That's all you need to control your HIV itself. There's very little other chronic conditions we have, that we treat in medicine that is completely, managed with a single tablet, and now even just a, twice monthly injection. And that's all that it takes to manage your HIV. And by keeping you sort of viral load suppressed, you live just as long as you would have with or without the virus, and you will not transmit HIV to any of your sexual partners. And so I try to frame it that way. And for sure, I think it's still, I always tell, like, when I give these lectures to residents and medical students, like, HIV is probably the easiest thing I can treat in my clinic. It's all the other bullshit that's attached to HIV that makes it so difficult. And that's why I make a big deal. I'm like, you made it through the door today. You came into clinic today. You are taking care of yourself. These are humongous steps you're taking, because you could have just stayed at home. You could have just avoided this appointment. You could have avoided all of this, but you didn't. You came in and you saw me, and I need to recognize that and acknowledge that, because that is really important. And I think trying to make a big deal out of these quote unquote small steps that they take, but are really big things for them to, feel empowered in their own health. But then I always compare it to other chronic conditions of, like, and again, like, while you have a chronic condition and I can't cure that right now, of other chronic conditions, this is some of the easiest things medically to treat. Now, the stigma piece is wholly different. And I do think U equals U plays a huge role in trying to dismantle that stigma. And that has dismantled a lot of stigma in the MSM and sexual minority male community that has not translated that well into the heterosexual community, and specifically among cisgender women. I think the U equals U messaging still has a lot of ways to go, specifically among cisgender women, and how they can feel like they are deserving of intimacy, deserving of a life and whatnot beyond all this.
And Dr. Hosmer, can you just tell the audience, if folks don't know what U equals U is?
Of course,
Awesome.
like, this is my favorite thing to talk about. So U equals U stands for undetectable equals untransmittable. For someone living with HIV who is on treatment, has a viral load less than 200 copies per milliliter, that's what we consider to be undetectable. They cannot transmit HIV to the sexual partners, period. There's no ifs, ands, or buts. There's no fine print. There's no asterisk or whatnot. If their viral load is under 200 copies per ml, which is what we call undetectable, they cannot transmit HIV. And so that messaging has been really important in, again, trying to destigmatize HIV specifically, and again, trying to allow people living with HIV the freedom to have intimacy, to feel like they are deserving of intimacy and deserving of life partners and whatnot. And again, that has done a lot of work specifically in the MSM and sexual minority male community, but there's a lot of work to be done among the cisgender women community living with HIV to continue to have that messaging.
So, Dr. Hosmer, do you mind, because I definitely am a firm advocate and supporter of the U equals U, movement and messaging. And I recognize that there is a critique of the U equals U movement in that not really thinking about the aging population that have been living with HIV for 20 plus years, and how those cocktails that they used to take, and how that like how they may not be able to be undetectable just because of, like, aging with with now this kind of chronic condition and all of the, kind of the biochemical response and stuff like that. So I just wanted to know what your thoughts were on that, because that actually came up more recently at an HIV conference that I attended, and I was intrigued.
Yeah. So I think when we think about people living with HIV for decades, for long period, people who are diagnosed in the 80s and 90s, when we think about life expectancy, and my comment before about staying undetectable means like an unchanged life expectancy, that is always not the same for everyone, and specifically people who have been living with HIV or have been so people living with HIV age in two different ways. They age chronologically, like everyone ages, from birthday to birthday, but they also age by how long they've had HIV for. That chronic inflammation for however long they've been living with HIV, specifically if they've had, high viral application early on and not be able to control, impacts how they age itself. But people who were diagnosed, I have a cohort of folks who've been living with HIV for 40 years and who are still undetectable to this day, and they still cannot transmit HIV as they are undetectable itself. So that U equals tells you still holds. But as far as like comorbidities and other sort of concerns, certainly HIV in aging population has special considerations that need to be met.
Thank you both so much. So as we conclude today's discussion, I'm wondering if each of you, and maybe I'll start with Dr. Hazra, can just share like one key step or one takeaway for the audience if they are striving to either like provide education and advocacy around HIV or like reduce stigma related to HIV.
Yeah, I mean, I would say like you start with your own social circles. Like you dismantle and reframe your perspective of HIV individually, and then you spread it in your own circles themselves. Talking to your friends, family, loved ones about PrEP and whatnot that makes huge changes and ripples itself. And if you feel again disheartened by what's going on nationally, you can start small in your own community with your own loved ones themselves and say that no, this is what it means to live with HIV now. This is what PrEP is and how people can protect themselves.
Excellent.
Yes.
Yes.
And then
No.
I would add that, even though I know the way that I talked about HIV is that we really need to address like kind of the macro issues, right? Around, kind of like larger social attitudes and gender norms and, structural inequities, it's a both and. While we're going to be champions and advocates to kind of change the social conditions that we live in from an equity lens, we also need to think about, there's day-to-day things that we can do, like using people first language, right? Like just thinking about the language choice, clearing up misconceptions that we hear, that people say, like those day-to-day things are so important around, that awareness and knowledge generating is really important so that, we have a common shared terminology and the way we think about and frame HIV disparities. Yeah. So I think that's really important.
And Dr. Ward,
invitation.
And Dr. Ward, can you just say what people first language is for folks who are watching?
People first language is, instead of saying an HIV infected person, right, or a homeless person, you would say a person who is living with HIV or managing HIV, a person who is unhoused, right? So you acknowledge that they're human and fully a person, and then you know like whatever condition that they're living in or managing. Wonderful. And that helps to reduce stigma.
Yes, yes. Thank you both so much for this very dynamic and I think uplifting and very hopeful conversation that we had. So thank you very much for your expertise and your time. And thank you to the audience for participating today. As we mentioned, a recording of today's discussion will be added onto NHMA's YouTube page and website within a week, and you will receive information when the recording is available. Next slide. Please remember that resources on HIV prevention and treatment for both clinicians and patients are available for members and partners, and these can be found on NHMA's website as well, and there'll be some resources that are put in the chat box. In terms of upcoming events, I'm really excited to share two around HIV/AIDS awareness. March 13th, we'll partner with various organizations for National Women and Girls HIV/AIDS Awareness Day on Threads. Please make sure to check out NHMA on Threads and follow us. And then next on April 10th, NHMA will host a National Youth HIV/AIDS Awareness Day webinar on Zoom. If you're interested in participating, please contact Makara Wright or Ashley Funes, and their information is on the slide. Next slide. Also, NHMA will be hosting its 28th annual conference in Anaheim, California from June 5th to June 7th. And so we encourage you, if you are interested, to join. There's a QR code on the slide where you can also register. And so join NHMA today and connect with healthcare professionals working to improve outcomes for Hispanic and Latino communities. Okay, wonderful. Yes. Become a member today. There's the QR code to become a member and some, I believe, contact information on the next page for the organization. So thank you again very much, and just sending lots of good energy out to everyone, and hopefully you can take that one key step or takeaway and put it into practice that Dr. Ward and Dr. Hazra shared. Thank you.